Now. So hello, everyone. This is Dr. Melanie Bechard. Did I say it right?
It's Bechard, but that's a very good guess.
My apologies.
No
Dr.
problem.
Bechard. She's a pediatric emergency doctor at the Children's Hospital of Eastern Ontario. She did her residency in pediatrics and her medical school at the University of Toronto. She's also done an MPH at Johns Hopkins. She served as the board of directors on both the Canadian Medical Association as well as the Canadian Doctors for Medicare. And she had completed a Bachelor of Science in Physiology and Psychology at the University of Western Ontario. So today she will be discussing the Canadian healthcare system. And personally, I would love to hear more about your interest in pediatrics and mental health as found on your biography. So yeah, without further ado, here she is.
Hey everyone, thank you. And did we want to introduce Karen Palmer now, or
I can
did we
introduce
want to wait until
myself
the
if you
Q&A
want.
period? I could also introduce you if you'd like, Karen, but
Sure. Yeah, that bio
you
is
can go.
way too long.
Okay. Um, well,
Your frozen
okay,
milk.
so I can share all about Karen Palmer. So Karen Palmer is an expert in Canadian health policy. She is a professor, I don't know your exact academic rank, at Simon Fraser University in British Columbia. And she has a degree in public health from the University of Hawaii. She has spent many years of her life in the United States and now, of course, lives in Canada. So she has a great perspective of working and living with health systems on both sides of the border. And she has also worked doing public health work in some of the most remote regions of the world. I learned what atolls were when I was reading your bio last time, because you've delivered healthcare in really remote island regions. So that's what I remember from your bio, Karen. You have been the health policy advisor to Canadian Doctors for Medicare since the organization first started. Oh, and just so everyone knows, my camera is haunted. It shuts off by itself and also will switch views spontaneously between my laptop and my actual camera here. So very distressing for me. Sorry about that. Karen, did you have anything to add to your bio or
No,
any
no,
corrections to
just
make?
to say that I was on the board of Physicians for National Health Program when I lived in the States, and now I serve as an advisor to them, which is, I think, how we all found each other.
Awesome. Well, let me see. You're getting like the weird under the chin shot view. If I use this camera, I guess I can look this way. 1 second. I'll move all your faces. Thanks for bearing with me, everybody. Today is an interesting day. I also woke up with a bit of a migraine, which is a lot better right now. But if I have word finding difficulties, that will be my excuse. But it's very nice to meet all of you. I can't say I've memorized all your bios, but it sounds like we have a great geographic representation across the United States. And I'm hoping that we'll have lots of time for interaction so I can learn more about, your experiences with the healthcare system and questions and things that you've had. I don't really have any conflicts of interest. I'm on the advisory board of the Medical Post. It's a medical focused newspaper in Canada, and of course, the chair of Canadian Doctors for Medicare. Our organization is really analogous to Providers for a National Health Program. We try to improve and strengthen Medicare in Canada, and we do our best to be evidence-based. So as much as I list it as a conflict of interest, I really and truly try to be driven by the best available evidence. So today I'd like to take you on a whirlwind tour of Canada's health system. We're going to cover history. I feel like this is a divisive topic. Some people are history nerds and love it, others not so much. But everyone here, I imagine, is a health system advocate or aspiring health system advocate. And seeing the work of advocates from prior years, I actually find really interesting, because how did Canada end up with this healthcare system that we have, which is quite a unique one in the face of the world? So we'll briefly cover some history. We'll cover some anatomy, health system anatomy. Don't worry, I'm not going to quiz anyone about the brachial plexus. We're going to be covering Canada's health system performance, and we're going to cover some hot topics and current issues, but there should be lots of time for questions. Of course, feel free to raise and ask questions throughout. It might be a little bit hard for me to monitor the chat, so feel free, if I don't respond, to just unmute yourself and interrupt. I know it feels rude, but I truly welcome it. It makes it way more exciting. Any questions before we start? Awesome. So let's get into the history. So taking it way back to 1867, when Canada was first made as a country, we had the British North America Act. And this basically designated the running of healthcare to the provinces at that time. That's because there wasn't a lot of healthcare in 1867. It was deemed to be something that, could be run on a regional level. The federal government does deliver healthcare in some circumstances. They are responsible for providing healthcare for Indigenous persons, for persons in the military, and also for people within the prison system, marine hospitals, and also for people under federal quarantine. So we like to say that Canada truly has 14 healthcare systems because each of the systems amongst each of the 10 provinces and 3 territories and the federal healthcare system are all a little bit different, but they do have some commonalities. Now, I would be very shocked if anyone knows who this is. If you do, feel free to type it in the chat. But I think most Canadians would struggle to recognize this face. This is a picture of Tommy Douglas. And he was a politician and also voted as the greatest Canadian because he had a big role in bringing forward universal health insurance in Canada. And he has kind of an interesting superhero origin story. Apparently, when he was a child, he had osteomyelitis, which, as you know, is a really bad bacterial infection of the bone of his leg. And it was looking like he might lose his leg because his family could not afford to provide him with care. However, they met an orthopedic surgeon who kind of took pity on him and said, look, I will treat you for free as long as you agree to be kind of a teaching case for the medical students and residents who I'm working with. So because of that, Tommy Douglas was able to access care. Oh, you're not seeing slides?
I am.
I can see them.
Okay. Sorry, maybe it's just an issue for Betty. Okay, let me know, anyone, if you can't see any of the other slides. In any case, this really instilled in him an idea that healthcare should not be dependent on your ability to pay, it should really be dependent on your need for healthcare. So he became the Social Democratic Premier of Saskatchewan. That's one of our provinces right in the middle of the country. And in 1947, he created a universal public hospital insurance, meaning that people in Saskatchewan who were admitted to hospital would not necessarily have to pay for their care. So this was a pretty landmark program at the time. And the rest of the country kind of caught on. So that in 1957, the federal government created the Hospital Insurance and Diagnostic Services Act. The federal government essentially said to each of the provinces, look, we will split costs with you. This is a 50-50 cost sharing agreement between the federal government and the provinces. If you agree to provide hospital care fully funded to the people within your province. It actually received unanimous support from all political parties, which just blows my mind in this day and age. I don't think that in Canada or the US we could see all the parties agreeing on anything. And within 4 years, all the provinces and territories had joined. So this made sense for a while because people could be admitted to hospital and have their care covered. But in order to see a doctor, if you had an appointment outside of the hospital or visiting your family doctor, none of that outpatient care was covered. So Saskatchewan, once again, really led the pack and they created the medical insurance plan. So that way, if you were enrolled in Saskatchewan in the 1960s, you would essentially have your medical care covered, not only if you're admitted to hospital, but also for all outpatient care. And you can see from this political cartoon that the doctors did not love it. So this is supposed to be a doctor in a lab coat. And this is Tommy Douglas and one of the other politicians at the time. So even though now many of us who work in our Canadian healthcare system are pretty proud of it, there is a lot of drama and a lot of hesitancy to its coming about. And unfortunately, physicians at that time were some of its biggest naysayers. In 1966, once again, the rest of the country thought, hey, this kind of makes sense. Let's create the Medical Care Act. So once again, this was a 50-50 cost sharing where the federal government said, we will cover half the costs for the provinces and territories to provide healthcare for outpatient medical services within your province. And within 6 years, all provinces and territories joined. It was also a very popular act. It didn't get unanimous support across all the parties, but out of the members of parliament, there was 179 in favor and 2 naysayers. So, kind of feel bad for them now in retrospect. And this was a major shift. At the time, 45% of the Canadian population did not have access to health insurance. So this truly increased access to healthcare in a tremendous way at that time. In 1984, another key piece of legislation came out. This is Monique Bechard, who was the Minister of National Health and Welfare at the time. And the Canada Health Act essentially stipulated some key aspects of Canadian healthcare that still persist today, meaning that it is publicly administered, that it is comprehensive, covering pretty much all health conditions, that it is universally available to all citizens of the province or territory, that it is accessible, and that it is affordable. Again, these are the principles. I don't know if we always meet these ideals, but this is what Canadian healthcare is supposed to look like. And what's also very unique is that the Canada Health Act essentially made it illegal to work outside of this system in a few ways. You, as a physician, aren't allowed to do extra billing. So if I, as a doctor, do a healthcare service and I am paid $45 for rendering that healthcare service, I can't suddenly say to the patient, hey, I'm going to charge you an extra $20. That's extra billing. That's not permitted. You also cannot ask for user fees. So if I'm a physician and I'm providing services that are publicly covered, I can't ask patients for extra money to be seen faster or for perks if those services are covered under provincial territorial healthcare plans. And this is a relatively unique feature. It's actually illegal to charge patients for healthcare services that are provided under the federal, under the provincial or territorial healthcare plans. There are a few small exceptions that we'll get into. I know it's a bit of an oversimplification, but by and large, that's the way healthcare works in Canada. And this has really persisted. Danielle Martin is actually the founder of Canadian Doctors for Medicare. She's a really cool doctor and healthcare advocate here in Canada. And she really encapsulated it that to Canadians, the notions that access to healthcare should be based on need and not ability to pay has really become a defining national value. In 2012, this is one of the more recent polls I looked up. I think we need to redo it. About 90% of Canadians identified Medicare as a source of national pride. And Tommy Douglas, that Saskatchewan premier that I had mentioned, was voted the greatest Canadian in a competition, I think, way back in 2003, even above hockey players like Wayne Gretzky, which is a pretty big deal for most Canadians. So that is the sunny side. We're going to get a little bit more into the anatomy and details and some of the areas where we don't always meet these ideals that we've set for ourselves. But before we do that, any questions, comments, surprises from anyone?
I have a question.
Go for it.
Do you mean comedian as in like a jokester, or is it something else?
Comedian?
Yeah, I'm sorry. I like as in I don't know how to describe it. Is it a
When
is
did
it-
she say comedian?
yeah, do you mean like comedian as in like someone who tells jokes, or comedian as like
Oh, I might be saying Canadian, but just not enunciating well. I'm so sorry.
oh
I talk really quickly. I'll try to slow it down.
I think you said he was voted as the greatest Canadian.
Oh, it's the greatest comedian. Oh, sorry,
Canadian.
maybe I did. You know what? We can watch the recordings to find out. He's the greatest Canadian.
Okay.
It would be hilarious if he did have a comedy career on the side. To my knowledge, he does not. Thank you for clarifying. Go ahead.
Bechard, I had a question, if I could. Could you explain the difference between, there was the one in 1966, I think it was called the Canada Health Act, and the one before that?
Yeah,
How did it
so
change?
we had the 1966
The
Medical Care Act and then the 1984 Canada Health Act. Excellent
the
question.
one before the
66.
1966.
This one, the Saskatchewan Medical Insurance Plan, or?
Yes. Oh,
Yeah.
that made it for the entirety of Canada after that.
Exactly. So this one was just for Saskatchewan for outpatient medical care. This was outpatient medical care for all of Canada. And the Canada Health Act really just solidified these principles and also made it illegal to charge extra beyond what the public plans were paying.
The Canada Health Act happened because doctors were charging extra. I remember in the 80s, my own doctor was like a bit embarrassed to say, you know, some of the doctors are charging $20. Do you have 20 extra dollars to pay me? I'm like, no, I'm a student. I have no money. And they then the Canada Health Act was brought in to stop that behavior on the part of physicians.
Unfortunately, a recurring theme is that physicians have not always behaved very well throughout our history.
I was going to say the bad behavior on part of the physicians, but I caught myself.
Yeah, no, it's fair. But that's why we have Canadian Doctors for Medicare, to counter that narrative and to provide education. So let's get into the anatomy of the Canada's health system. Now, why is health system anatomy important? I think that when you are trying to find how well a system's doing and how to improve it, you need to know its structure. And it's really similar to body anatomy. So I work as a pediatric emergency doctor. Because I've studied anatomy, I know that these lines in the bones are not fractures, they are growth plates, and that's totally normal for kids. So health system anatomy, very analogous. That's the only medical content in this presentation, don't worry. There's two main aspects to health system anatomy. The first one is financing, and this is simply who pays for care. The next one is delivery, and this is simply who delivers care. So far, so good. And for each of these, it can either be public or private. So when we think of examples of healthcare delivery that is private, some people are surprised to find that in Canada and in most provinces, at least in my province, a lot of our hospitals are actually private institutions. They're not government run, and our physicians are not government employees. So for me, I essentially work as an independent contractor. The hospital I work at, CHEO, it's our children's hospital in Ottawa, is a nonprofit institution, but we're not government run. So technically that is private healthcare delivery. However, we are publicly financed because when children come to see me in the emergency department, unless they're traveling from abroad, all of them typically will have public coverage through their provincial healthcare plan. So they just need to show their health card and they are not charged any fees to see us in the emergency department. So that's an example of public financing and private delivery. Can anyone think of an example of public delivery and public financing, either in the States or perhaps in other countries?
The Veterans Hospital?
Yeah, exactly. The Veterans Affairs is a great example, but another example that comes to mind, and this is changing a little bit, but a lot of hospitals in the United Kingdom through the National Health Service or NHS will have public delivery. So there's public hospitals that are government institutions. Some of the physicians will work as government employees and the care will be publicly financed. I should mention as well, this is a gross oversimplification. I'm sure Karen is like thinking of thousands of exceptions for both of these boxes. They're just to provide a few illustrative examples. For private delivery and private financing, this could be private insurance. So for anyone who has like United Insurance in the States, who are seeing private healthcare providers where that care is financed either out-of-pocket payments or through your private insurance. That would be an example. We also have many examples of private delivery and private financing in Canada, but I'll get into that shortly. All right. Now here's a trick question. Does Canada have universal healthcare? So we can take a little informal poll. If you're brave, you can raise your hand. Who thinks, yes, Canada has universal healthcare?
Can you define universal?
We're going to get to it. Karen's not sure. Yeah, okay, see a few hands, right? You're like, that's the whole thing. Isn't that kind of your whole personality? Who thinks Canada does not have universal healthcare? And who is just very confused by the question? So I think, yeah, exactly. And sorry, it's intentionally confusing because the whole point is, what does universal healthcare mean? And that actually depends. Now, I really love this approach by the World Health Organization. This cube is very confusing, but don't worry, we're going to focus on one part at a time. So the first aspect of universality is financial protection, meaning what do people have to pay out of pocket? So having 100% financial protection would mean, last night I was working in our emergency department. I had a child who was riding their bike, they fell down, they cut open their chin, they came to the emerge, we glued it back together, looked great, they got a popsicle, everyone wins. They had 100% financial protection for that healthcare encounter because they showed their health card, they didn't need to pay anything. Examples where you wouldn't have 100% financial protection could be, let's say, if you have private insurance that will cover 50% of your hospital costs, but you're on the hook for the other 50%, for example. So the degree of financial protection is one element of universality. And for Canadian healthcare, for the services that are covered under our public healthcare plans, you typically do have 100% financial protection for those services. Next up is which services are covered. So in Canada, we have pretty comprehensive coverage of services. There are a few exceptions. Let's say I want to go and get a rhinoplasty. I don't like how my nose looks. I'm getting cosmetic surgery. That is not publicly covered. I would need to pay for that out of pocket because it is not deemed medically necessary. If I have a really bad deviated septum and it's causing me issues with breathing through my nose and mouth breathing and causing cavities, then in that case, I could get a rhinoplasty that is deemed medically necessary. Okay, so that's an example. In many low and middle income countries, there's less comprehensive coverage. Some nations have prioritized just providing like maternal care and antenatal care, as well as vaccines for kids because they have limited resources and they deemed those to have like a higher public health benefit. So the degree of services covered involves a service coverage aspect of universality. And then last but not least, the population, who is covered? So is everyone covered? In Canada, we have pretty broad coverage. If you are a citizen or if you are a refugee claimant who has been in the country for 3 or more months, typically you will have coverage either through your federal or provincial territorial health plan. So whenever you're thinking of universal health care, and this can apply to any healthcare system, not just Canada, you look at whether or not there's financial protection, the degree of service coverage, and who in the population is covered. And really and truly, by this definition, there is no country in the entire world that has 100% universality, where every service imaginable is covered for full financial protection for everyone who crosses a border into that country for any reason. That just doesn't exist because no country has limitless resources. Any questions about that before we move on looking at the details of what's covered in Canada? All right, so let's take a look. So as I've mentioned a few times, when we look at Canadian healthcare, for a lot of our outpatient care, there's zero cost to patient if it's medically necessary. So if I visit my family doctor for a sore throat, if they refer me to a specialist for chronic back pain, if I have my Ontario health card, I don't have to pay for that. Hospital care typically is also covered. So if you're in a motor vehicle collision and go to your emergency department, if you've got your health card, you're covered. Same thing if you have an appendectomy. There are a few gaps, though, because I mentioned the legislation that covered outpatient care and hospital care delivered by physicians. One big gap in healthcare coverage in Canada right now is outpatient prescription medications. So this is kind of wild because if I go to the hospital with appendicitis, I get IV antibiotics. All those IV antibiotics are covered by my provincial healthcare plan. If I'm discharged and need to continue on IV antibiotics at home, I now need to pay to get those oral antibiotics, provided to me at home. So any prescriptions that you fill outside of the hospital setting are not necessarily going to be publicly covered. And which drugs and who's covered varies by every single province and territory. So I live in the province of Ontario, and there are a few groups that will have their medication costs covered by the government. One is Ontario Works. So that's essentially our social assistance or a welfare program. If you're on the government disability support program, people who are 65 years or older, if you're 24 or younger without private insurance, this is a relatively new change that came about in 2015. People who are living in long-term care or residential care, those who are receiving professional home and community care services. And then also we have the Trillium Drug Program, which means if you spend 4% or more of your after-tax household income on prescription drug costs, then the government will step in to help you. But this differs between every single province and territory. So you can imagine it is very confusing because we have 13 different provinces and territories and the federal government. And we will cover how there are current movements within Canada to try and cover outpatient medication coverage, or what we call pharmacare. I don't know if that's a surprise to anyone that we don't cover outpatient medications. It's pretty funny. We'll like cover you to go see the doctor, but we won't cover the medications that the doctor prescribes. Next up, when it comes to long-term care or home care, it's typically also not covered. There are a few exceptions. So if I have an elderly grandparent who has medical needs, who needs to be in a long-term care facility, the personal and nursing costs can be covered by the government. But to actually stay at the facility, the rent will not be covered. There are some subsidies available for low-income seniors, but as you folks probably know, whenever you have these patchwork programs, it can be very hard for people to be aware of or to navigate the application process. Dental care, this is changing, but it also typically does not have public coverage in Canada right now. There are some new programs to try and address this. But in Ontario, if you're having a surgery in hospital on your teeth, that is covered. If you have a necessary tooth removal, so if you have an abscess, we'll pay to remove the tooth, but we won't pay necessarily to put in a new implant. Those who are 65 or older with low income and don't have private coverage will be covered. Some people under the age of 17 with lower income, and if you're on disability support, some dental care services will be covered. But by and large, Canadians will buy private insurance for their dental care, or they'll have dental care covered through their work, or unfortunately, they just pay out of pocket. And as a pediatric emergency doctor, I do see some of the effects of this for children who were not able to access dental care in a timely manner, who then come to the emergency department with dental abscesses or teeth that need multiple extractions requiring surgeries under a whole general anesthetic that our public system will pay for. But it's a bit of a shame because we probably could have prevented it with better preventive dental care. So that's about service coverage. Any questions about that? I don't know if anyone's surprised to find out these gaps in Canadian healthcare and how, we're somewhat universal, but not really.
May I ask a question about your pharmaceutical coverage? I've heard that Americans oftentimes want to purchase drugs up in Canada because they can get them cheaper. Why is it cheaper in Canada if they're not covered? And is it cheaper for those that are not covered in Canada than it is compared to the United States?
Yeah, excellent question, Chris. So I will say Canada has, depending on the ranking, the third or fourth highest drug prices in the world. Right now, the United States has amongst the highest drug prices in the world. And there's a lot of complicated reasons for that. I can't pretend to be a whole expert in it, but I did my MPH degree at Johns Hopkins and attended a few seminars on like pharmaceutical system in the United States. And I think a lot of it comes down to it being a really fragmented system with a lot of players. There's essentially a lot more complexity in the pharmaceutical system in the States with like pharmacy benefit managers and how the prices are negotiated that end up like really inflating the cost of medications in the USA. That being said, I think it's cheaper in Canada, and I think we see Americans coming up here because it's like geographically close to get to. But we are definitely not like a model of good drug pricing. Our pricing is the third or fourth highest in the world, largely because we have this multi-payer system. So in countries where they have like a large federal purchaser, they're able to purchase their medication in bulk, as opposed to right now where every single province and territory and every private insurance company is kind of negotiating the drug prices separately. You essentially can't negotiate lower drug prices because you're not buying in bulk. It's like the difference between buying at Costco or like your favorite wholesale retailer versus like the little boutique shop down the street. So that's part of it. But there's a lot there. Karen, I don't know if you have anything else to add about the differences in drug pricing and why it's a little lower in Canada than in the States.
We have laws that that cap prices on drugs. There's ceilings on drug prices. We have the Patented Medicine Review Board. I mean, there's lots of reasons why the drugs are cheaper here. But part of the reason why they're higher too is because one of our comparators is the United States. So people are trying to remove the United States as a comparator and have median prices of drugs be more closely aligned with other countries like France and Germany and most of the European countries, and exclude the United States as a comparator.
So, and I see Sam. Yeah, thanks. Great question, Chris. I see Sam and then Marcelin have a question. Go ahead, Sam.
Yeah, I also had a question about the drug coverage. So given that there's no like guaranteed outpatient drug coverage, do you find that people go to the hospital to try to get prescriptions filled? Does that like bog down service at all?
Oh, excellent question. Unfortunately, even if you get the prescription filled at the hospital, if you're an outpatient, like not admitted to the hospital, you still have to pay for it. So it's not really so much where you get it filled, it's more whether or not you are currently admitted to a hospital. So it is a bit of a shame. I know my friends in adult medicine see this more. I do see it to a bit of an extent sometimes in pediatrics, where if kids can't take their asthma inhalers regularly, they end up coming to the emergency department more often, sometimes even getting admitted, and we can stabilize them there. But if they can't take their preventive meds, they often end up back. My friends see it a lot in patients with diabetes, because they'll come to hospital, be stabilized, be prescribed all this diabetes medication that they'll get in hospital. And then as soon as they step outside, they need to start paying. Good question.
But I think it's important to note that the
Rosalind?
vast majority of Canadians have private supplemental drug plans through their employer.
Mhm.
That's the majority of Canadians, like most. And then, in my province in British Columbia, we have fair pharmacare. So if your income is, I mean, you'll never pay more in this province than $10,000 per year. If you have an income between over $316,000 a year, you'll never pay more than $10,000 in drug benefits for drugs. So, and the lower your income, the less you'll pay, because we have a pharmacare program in this province. Yeah.
I was
Yeah,
actually just
exactly.
going to ask exactly that. So
And it's just a good
I'll put my
example.
hand down.
Go for it.
I was going to ask exactly that, if there was a cap for a yearly, because
Okay.
of
Yeah,
co-pays and whatnot.
there's the chart right there. I just posted it. It's how the fair pharmacare assistance levels work
Mhm.
in BC.
Yeah, and as you can see, there is like some public support available in Ontario with the Trillium Drug Program. Again, most people do have private drug insurance coverage. I have private drug insurance coverage. It's pretty good. I had to pay for it. That being said, as we all know, private insurance, for many reasons, is not a great way to deliver necessary healthcare. Sometimes you have really high co-pays and deductibles that can end up being a barrier in access. So even though you might be eligible for a coverage program, either privately or publicly, it doesn't always mean that you're able to take the medications in a way that they're prescribed. But yes, Karen's right. It's not like, I think most people are able to access their medications. In surveys that we've done, about 10 to even up to 20% of Canadians do struggle to take their medications exactly as prescribed. So it's not a majority, but it's not an insignificant amount.
This has been a big issue for physicians, of course, because they, want to take good care of their patients. And for that proportion of patients, as Mel announced, it's about 15% of Canadians who have less than ideal drug benefits. But that makes a difference to physicians, that 10 to 15% of people that can't easily access their drugs that they
And I
need.
see Betty in the chat is looking for someone who might have space to help record it on the computer. Oh, it looks like I'm not the only one having computer issues, though. I'm sorry, everyone. Thanks for sticking with me. Let's get into the degree of financial protection in Canada. So as I mentioned, it tends to be pretty good. There's this one interesting study done in Canada in 2014 that looked at over 500 people who had declared bankruptcy from 2008 to 2010, and found that even in Canada, 22% of bankruptcies were due to medical bills, or at least the people who were in debt and declared bankruptcy said that they felt like it was mostly due to their medical bills. What's also really interesting is that the vast majority of these, so 93%, were for medical costs that amounted to less than $5,000, which is not an insignificant sum, but it's not a lot. So it's clear that these are folks who are probably already financially vulnerable, where there is 5K standing between them and bankruptcy. So we do have some protection, but unfortunately, it seems like it's not really reaching the folks who really need it most. And a lot of these medical costs ended up being medications and dental costs, which makes sense because as we've covered, those are some of the current gaps in our system. But again, I know in the United States, medical debt and bankruptcy due to medical costs is a far more prevalent problem, but I just wanted to highlight that it's not completely unheard of here in Canada. Same thing with our population coverage. It's pretty broad. If you, again, are a citizen of your province and territory, you're afforded with a health card, which pays for your outpatient physician care and your admitted hospital care. There are a few exceptions, though. We do have a few uninsured people in Canada. And estimates of this are really hard to come by because most of them are undocumented people or folks who are living in kind of precarious circumstances where they're not always counted on the census in the same way. So the best study I could find was done in 2012, and their estimate was at about 250 to 500,000 people across the country did not have access to health insurance within Canada, which would have been about 1.4% of the population at the
Or
time.
drugs. Are you talking
I was
about
trying to
drugs?
look for data from the United States. No, medical insurance, like
Oh.
health insurance, like hospital or physician coverage. Again, this is an estimate. A lot of these folks are probably undocumented individuals or people who are refugee claimants who are denied their claims, who are essentially likely going to be deported, but we're trying to delay that process. There's also a 3-month waiting period if you're a refugee claimant coming into Canada before the health insurance kicks in. So that could also include the people living in that gap. So it's not unheard of. And again, it's hard to estimate. So I'd take these numbers with a grain of salt, but we do sometimes have folks without medical insurance in Canada. I was looking for
Generally
numbers
speaking,
in the
people who are
States.
lawful
I looked at
residents are insured.
in the United States, I was looking at the morbidity mortality report journal back in 2022 and found that 14% of the US population 18 to 64s was uninsured in the year of 2019 to 2020. So, you know, maybe 10 times order of magnitude higher. So I don't need to tell folks here that, you know, lack of access to any health insurance is a problem in the United States and to a much smaller degree, a problem in Canada. Now, let's look at Canada's health system performance. And Karen, I know this is going to make your blood boil because I didn't use the perfect data. These are just some jumping off points. I think these data come from like 2008, so they're getting pretty old.
Oh, those are old. Yeah.
I wanted to compare some of the different countries that we have here. When we look at total health expenditures per GDP, when we compare to some of these other high-income countries, Canada is fairly middle of the pack. The United States is a bit of an outlier in terms of the health expenditures per GDP. When we look at the amount of health expenditures that come from public sources or government sources, a lot of people are really surprised to find that in Canada, 70% of our health spending is from the government and 30% is from private sources, meaning private insurance or out of pocket. So when you compare to other countries like the UK, France, Denmark, they all have a much higher proportion of health spending from government sources. And a lot of this comes from, you know, our gaps in pharmaceutical coverage because drugs are getting ever more expensive, our gaps in dental coverage, et cetera. And I thought this was really weird. I would like to investigate this a little bit more. But when we look at the percentage of total health expenditures that come from out-of-pocket sources, this data said 13% in Canada versus 11% in the US. So paying for healthcare out of pocket is not unheard of here, unfortunately.
But
Now,
that's
when we-
including dental care, that's including drugs, that's including hospital and physician services are 100% publicly funded.
Exactly.
Nobody
Exactly.
pays for those.
Now, when we look at the total expenditures on pharmaceuticals, we can see that a relatively high proportion of our health spending is on pharmaceuticals. Again, our pharmaceutical costs are typically lower than in the United States, but still relatively high when we compare to other high-income countries for the reasons that we spoke about. What's also really interesting is when we look at the income of our physicians, it's relatively high compared to many other countries. I think we're just kind of a little bit below what physicians make in the United States on average. Because our system is so publicly funded, I think that that's really interesting because we are having physicians who are making relatively high amounts of funds off of the public funds. So when I look at ways that we might need to improve our healthcare system, sometimes I do feel a little bit guilty as a physician thinking that maybe we need to improve it, but also the medical systems and the training pathways are so different between all these different countries, and sometimes the salary reflects that as well too. So it can be tricky to compare. What I do think is really fascinating as well too is that we do have a health technology assessment agency. So basically a group that looks at new drugs or medical devices and says, is this effective and is it cost effective? Does it do things at least as good for the same amount or less cost than the other drugs or devices in this market do? So we have CADTH, the Canadian Agency for Drugs and Technology in Health, that helps to assess that for us. There's different bodies in some high-income countries, and the USA really has much more of a free market model. So if I make a drug that, you know, the FDA deems to be like safe and effective, even if it's more expensive or not as cost effective as other drugs, I can still market it really hard and get it covered into different private insurance plans and get it into patients. So that's also another area I think that is really interesting and I think relatively unique about the US healthcare system. But I'm not an expert on your system. I'm more familiar with mine. So of course, take any US perspectives I have with a grain of salt. Now, this is where we really interrogate access to healthcare in Canada. So these data, again, they're getting pretty old right now, 2013 and 2016, but this is the proportion of people who sometimes, rarely, or never get an answer from their regular doctor's office on the same day. So high numbers are bad. This means it's hard for you to hear from your doctor on the same day. And Canada has amongst the highest amongst all these high income countries. When we look at the share of people waiting 1 month or more for a specialist appointment, again, Canada has amongst the highest in the world from 2010 through 2016. But we have really tried to reduce wait times. These are some data from 2018. It's really hard to get post-pandemic data. I'm hoping that we'll have more soon and I can update these slides. But when we look at the median waiting time from specialist assessment to treatment in days, Canada actually is a little bit below the OECD 10 average or OECD 17 average. When we look at the median waiting time from specialist assessment to treatment days for, oh, sorry, I didn't mention that was for cataract surgery. This is for hip replacement. We're kind of on par with the average amongst these high income countries. And when we look at the waiting time from assessment to treatment in days for knee replacement, Canada, once again, kind of on par, just a bit below that average. So these are some high priority procedures where we actually have really tried to invest some resources to try and decrease these wait times. And for certain procedures that are more urgent, back in 2018, we had amongst the lowest coronary bypass median wait times in the world, where it was 24 days on average through the OECD and 6 days in Canada. And for prostatectomy for prostate cancer, those wait times were 40 days in Canada compared to 51 in the OECD. So I think a lot of folks, when they hear about Canadian healthcare, you know, think of folks who are saying, oh, there's tons of Canadians dying on wait lists all over the place. Sure, Canada's a great healthcare system, but it'll take you 3 years to get an appointment. And definitely wait times are a problem. But let's be honest, there's no country in the world where there's no wait times for healthcare. We all have limited resources and have to prioritize them accordingly. And in Canada, we've just made a conscious choice to try and not prioritize based on your ability to pay. And we have data supporting that this has actually kind of worked out. So this was a study of surgical waiting times, I believe, in the province of Ontario. And we have the different socioeconomic categories here with different degrees of deprivation, where purple had more economic deprivation, yellow being, sorry, least economic deprivation, and orange being more deprived. So essentially, quote unquote, richer folks in the purple, poor folks in the yellow. And we can see that when we compare these categories over the years, if anything, those who had more economic deprivation did have like maybe shorter waiting times, but there was no significant difference between them. So all that to say, your surgical wait times are not influenced by your socioeconomic status when it's been studied. And by having this single payer system, we do have a few administrative efficiencies. When we look at healthcare spending on administration, there's much different values depending on exactly what aspects of spending you're comparing. But in Canada, we typically see that a much lower proportion of health spending is spent on administration, like insurance overhead, administration of government programs, at the hospital level, home care, nursing homes, physician services. This is quite different. We see, depending on the study, anywhere from like 2 to 10 times more spending on administrative healthcare services in the United States compared to Canada. So having a system that is mostly single payer is more efficient. And I have to say, as a physician working in the system, I really appreciate the efficiency. I'm a big fan of Med Twitter, or I used to be before Elon Musk took it over and the website went in a different direction. But I hear lots of stories from my colleagues in the States, and I have a few friends who practice south of the border who do talk about, depending on their practice setting, how hard it is to, seek reimbursement from insurance companies. I've had friends who have had to who had medical insurance in the States, but who had to be on the phone with their insurance company for like 6 or more hours to try and get things reimbursed properly because they didn't go through. And I'm just really grateful that as a physician in Canada, I'm actually salaried. Not all physicians are. And when I bill the hospital for services, I literally just click a button. It's covered under the provincial healthcare program. I have spent 0 minutes in my medical career needing to work with insurance companies to get things covered for patients, or trying to track down payments so that I can make a living. And for that, I'm very grateful. There's a lot of other inefficiencies and administrative annoyances that I deal with, as all physicians, as all adult humans do. But I'm grateful that I at least don't need to argue with insurance companies typically. Now, I think the COVID-19 pandemic was obviously really, really tough for so many of us across the world. There's a really interesting article that came out in the Canadian Medical Association Journal in 2022, looking at some different metrics of healthcare performance. And I was actually pleasantly surprised to see Canada did pretty well on par with some of the other high-income countries. When we look at the proportion of the population fully vaccinated against SARS-CoV-2, we had amongst the highest at that time in 2022. When we look at the cumulative confirmed COVID deaths per million, Canada was relatively low, just above Japan. And there's so many reasons for this. We're really comparing apples and oranges. Every country's healthcare systems and population is so very different. But I do like to think that some of the accessibility in our healthcare system, and especially given how through much of the pandemic, the worst effects were felt by people who had more social marginalization, I think having that accessibility can really help those populations who are more vulnerable to the pandemic. That's just my hypothesis. So our healthcare system, as much as you've heard me complain about aspects of it, I think is pretty good. So for our physician and hospital services, we are publicly funded and have single-payer healthcare, nearly universal population coverage, as Karen said, for everyone who's quote unquote lawfully within the country. We have pretty good equity. We do have wait times, but at least one of the factors that affects your wait times is typically not your socioeconomic status. It's fairly simple and straightforward, which keeps our administrative costs low. And adverse selection is an interesting concept in economics. This is essentially when you have a multi-payer system where you've got your private insurance and then your public insurance. And typically private insurance is held by people who tend to be healthier because they have the funds to purchase it, or they're working in jobs which requires a baseline state of health, meaning that a lot of your healthier people are having private insurance coverage, meaning that your people who have more health needs, who have more health complexity, are relying on your public system, which can really drive your public system costs up. So because almost everyone is covered in our public system, the whole system's bearing that risk and that complexity, rather than having the private insurance companies take on people who tend to have fewer healthcare needs, and the public system needing to make do with fewer funds with people who tend to have higher needs. So again, as I mentioned, it was actually in 2004, Tommy Douglas was voted the greatest Canadian. I'm going to try to really enunciate this time. Sorry for the confusion. And again, even over Wayne Gretzky, even over Sir Frederick Banting, which many of you might know is the physician who discovered insulin. And even back in 2012, 94% of Canadians considered Medicare a source of national pride. So there's different surveys that we've done. In general, I think it's still a relatively decent focus. Now, this is a photo of what I like to call my office. This is a resuscitation room in our hospital. I need to update the photos. This is in COVID time when we had tarps there. We usually don't have tarps anymore. That was just to minimize aerosol spread. But just working as a physician in the Canadian healthcare system, as much as I spend a lot of my time with Karen and my colleagues at Canadian Doctors for Medicare trying to make it better, I am very, very grateful that the vast majority of time in my career is spent on delivering healthcare and medical needs and not needing to worry so much about how people are going to have to pay it, which is wonderful. I've not had, to give bad news to a family and then have them worry about how they're going to afford care for their child. And hearing the stories of people who have gone through that, either as healthcare providers or patients, it is really heartbreaking to hear. And I hope that we can maintain that level of access in our country and also improve it. Now, let's talk about some current issues. Some of them have come up a little bit. I've spoken about pharmacare. Depending on a survey, like Karen, I said, about 10 to 20% of people cannot afford to take their medications as prescribed. Various studies have shown that if we were able to provide full funded public pharmacare to Canadians, we would save ourselves even $4 billion per year through reduced drug costs, through lower complexity, lower administrative costs. There's been estimates that it would also prevent 200,000 ER visits per year and 90,000 hospitalizations per year. Because right now we are paying publicly for the effects of folks not taking their medications, but not paying publicly for their medications, other than in a few circumstances. Now, this is, I think, I've left it on here as a current issue in Canadian healthcare, but I think that it is one that has concluded. Some of you may or may not know, but there is Canby Surgeries Corporation, which was essentially a surgical clinic in British Columbia, that brought forward a case saying that it was not lawful for Canada to prohibit extra billing and user fees. They wanted to challenge that. They also wanted to challenge private duplicative insurance. Right now, I cannot purchase private insurance for health services that are covered under the public healthcare plans. And some provinces allow what we call dual practice, or sorry, some provinces allow you to practice either in the public system or in the private system. So not all provinces do this, but if I was in British Columbia and I wanted to just charge privately for medical services, I could do that, but I could only charge privately. I could not also charge the public system for my services. I essentially need to opt out of the public system. And it's really hard to make a medical living and career only off of people who will pay privately, especially because I'm offering services that are already publicly covered and free. So this restriction on dual practice is essentially to discourage physicians from opting out and going that private pay route. But the Canby Surgeries Corporation wanted to challenge all these aspects for the BC Medicare Protection Act. It ended up going to the BC Supreme Court. And after, was it a 4-year trial from 2016 through 2020, they released an 880-page verdict that essentially said that charging people for medical care would not decrease their wait times. It would really just worsen the inequity in our healthcare system. The Surgeries Corporation appealed this decision to the BC Court of Appeal, and they actually shut down the appeal, saying, no, the ruling of the first court stands. They applied to be heard at the Supreme Court of Canada, and the Supreme Court of Canada actually declined to hear their case, saying that, no, this is a sound ruling. So the way that I've heard it explained to me that I really like is that charging people for care doesn't decrease your wait lists. It doesn't give you more doctors or places to do surgery or other healthcare providers. It just rearranges your wait list so that those who have more money are seen faster, but those who rely on the public system often wait just as long, if not longer.